about to begin. Good day and welcome to the Realities of PCMH conference call. Today's call is being recorded. At this time, I'd like to turn the conference over to Eric Levin. Please go ahead.
Thank you. Good afternoon, everybody, and welcome. My name is Eric Levin, and today we're going to be talking a little bit about patient-centered medical home, what it is, what the realities are, dissect it a little bit, and go into a high-level overview of really why PCMH was created, the primary care landscape, what's happening in healthcare today, what does PCMH mean, and why it's important. A lot of people believe that this is something coming in the future, but the real reality is that it's happening today. It's been going on for the last few years, and we'll take a look at what is happening and why that is. So to really analyze patient-centered medical home and know why it was created, we have to start with the United States healthcare situation. And currently we're looking at some astronomical spending rates. As far as the USA, this affects physicians, patients, and health plans. We currently operate on a fee-for-service model, which means the more patients a doctor sees, the more procedures that are done, the more they get paid. This is a broken system. What this leads to is sicker patients, longer wait times, and more spending. So the healthcare system faces a lot of challenges. We really need a payment system reform to go from fee-for-service to a more value-based payment system. We're working on a reactionary focus, which focuses on symptoms rather than proactive health management. We have a lot of fragmentation, meaning that care is not coordinated between primary care specialists, hospitals. Resources are not being directed towards primary care, and we'll take a look more at this later. The system is not designed around the needs of patients, and treatment decisions are not always based on the best available clinical advice. So the primary care landscape today, we're looking at physicians are undervalued, underappreciated, under-reimbursed. This has led to a reduction in pipeline, meaning that not many people are going to medical school to become primary care physicians or going to become specialists or even other specialties. A lot of physicians are going into retirement and they're facing financial issues in their practice. So this is creating primary care doctors to sell their practices. They're becoming employed by hospitals or health systems. The outcomes of this mean that a physician is going to lose their autonomy. They're being told how to practice medicine. They're being restricted as far as what EMR technology they can use. Their salary typically decreases, more red tape, more paperwork for them to do. Primary care doctors are typically overwhelmed as we see them today. If you look at a primary care office, they're receiving about 23.7 calls per day, 18 emails per day, and 80% of those calls are being handled directly by the physician. So this leads to them being exhausted, overworked, and underpaid. In 2014, we're going to see about 30 million Americans with insurance for the first time. We already have a physician shortage, and due to lack of students in the pipeline, the wait time for a primary care doctor, we're looking at a 3 to 4 month wait just to see a primary care doctor for a regular appointment. This is going to create a schedule implosion that primary care offices typically aren't prepared to handle today. So primary care is in trouble. There's a lot of non-reimbursable work being done, a lot of overwhelming work. They're poorly compensated, making about 65% less than specialists. The pipeline is drying up. We're seeing a lot of retirement. A lot of people go non-primary care. We've got an aging, sick population. About 52% of the population has a chronic disease today, which creates more complex patients for primary care doctors to handle. Healthcare costs are skyrocketing. Quality and coordination lag, especially between primary care doctors, specialists, and hospitals. and overall we are seeing a physician frustration. So what can we do about this? What is being done now? Well, the Patient-Centered Medical Home was created to help alleviate some of these issues. And this is simply an extreme makeover for primary care practices. It's going to make you more service center oriented, more effective, meaning better patient outcomes, more efficient, meaning reduced cycle times, and more fun to go to work for staff and physicians. It's not necessarily about the name. There are several different names for it, but Patient-Centered Medical Home is probably the most popular. Patient-centered care, high-performing practices, advanced primary care, accountable care are all synonyms for this. This is really the original concept of primary care and probably the main reason why a lot of family doctors went to medical school in the first place. PCMH, to take it a little further with the definition, is really a stepping stone to accountable care that uses care coordination, care management, team-based care to focus on preventative medicine and positive patient outcomes. The triple aim is something that most people have heard of or are familiar with, and this really is the heart of PCMH, and this is improving the patient experience, improving the health of the population, reducing the overall cost of care. And how is this done? Well, these are the terms that we'll go over and we'll kind of dive into in a little deeper basis, but care coordination, management, team-based care, health IT to really measure and improve outcomes, and then relationships between staff, between patients, between physicians. So what does this mean for a medical home? What does it mean for a primary care practice to become a medical home? Well, it's really a transformation from fee-for-service world to a value-based, patient-centered medical home. In fee-for-service world, the objective is productivity, like we talked about. The more patients you see, the more you get paid. In a medical home, the objective is patient outcomes. The objective is getting your patients healthier. It's focusing on the total needs of the panel. It's actually coordinating care of those patients and delivering care management by the primary care practice. In a medical home, we're looking at measuring and tracking gaps in care. We're looking at using population management to understand the entire profile, prioritizing patients in high, medium, low-risk buckets, and then proactively engaging and tracking performance of that patient and those practices. So there's a big overlap between PCMH and meaningful use. And if you look at the actual definition of meaningful use from CMS, meaningful use is using a certified EMR technology to help quality, safety, efficiency, and reduce health disparities. This was created to improve clinical quality, engage patients and families in their health care, improve care coordination, improve population and public health, and maintain privacy and security. As you look at meaningful use stage 2 and 3, well, stage 1 was really to get doctors digital, get them using something electronic, away from paper. But stage 2 is going to include things like clinical decision support, reminders for preventative care, quality improvement, patient-specific education resources, and providing summary of care records to specialists. Things like generating lists of patients by specific conditions to use those for actual quality improvement. And as we look towards stage 3, we're going to look at focusing on improved patient outcomes. So meaningful use ties right into the patient-centered medical home. There are 6 key components inside of a medical home, and we'll dive into each one of these individually. But whole person orientation, care coordination, continuity of care, enhanced access, personal provider, safety, and quality. So starting with a personal physician. The personal physician really leads a team of individuals at the practice level who will collectively take responsibility for the ongoing care of patients. This means that the staff will work at the top of their license. The doctor has the ability to delegate tasks, to free themselves up to spend more time with the patients. There's a shared decision-making between the patients and the physicians. And this really builds the relationship between patients, the physician, and the care team. Whole person orientation means that care is organized around providing services for all the individual's healthcare needs. This might include taking responsibility for arranging care with other qualified professionals with an on-needed or as-needed basis. Taking the accountability of the patient's overall health will fall on the primary care physician. So if the patient is seeing a nephrologist, it's not necessarily the nephrologist's responsibility or the cardiologist's responsibility to manage that patient's whole orientation. Care coordination involves coordinating care across the spectrum of specialists, hospitals, home health agencies, nursing homes, and using the personal physician to lead the effort. Some specific care coordination tasks would be sharing a care plan, clinical information, arranging appointments for a patient, tracking referrals, tracking labs, consultations, making sure to follow up on reports, recommendations, engaging family and caregivers with that patient's health care, and then even setting up service agreements with other providers or people they're going to refer their patients to. So the care manager is really a person that will reach out and turn the dial up on patient outcomes by making population health management personal. Typically, it's a registered nurse inside of a practice that works as a care manager. A lot of health plans are providing care managers for family physicians at no cost to the practice because they're seeing a lot of benefit in this, and we'll go more into what the health plan's involvement is in just a minute. But some of the care management tasks, formulating the care plan with the patient, agreeing on goals for treatment with the patient to have them involved, using a patient registry for data management, and then also some self-management techniques for the patient to actually use so they are engaged and they're participating in improving their health. Educating the patient, home monitoring can be done, things like in-between contacts or reminders, encouragement through email, through text, by the phone. The big critical key is developing a link between medical and social. Disease management, utilization management, transition management, making sure that the patients are compliant with the medications as well as physician instructions. So advanced care coordination is really going to focus on the office care manager and aligning that care manager with practice staff, the physician, nurse practitioner, PAs, the health plans, the integrating with the specialists, hospitals, and other providers that they're referring services to. Evidence and outcomes-based focus really means that quality and safety of care are going to be improved by a care planning process. So we're going to use actual evidence-based medicine, clinical decision support tools, performance measurement, and active participation of patients in decision-making. So using health IT like a registry, population management tools, even the EHR, is going to help measure success by outcomes and by dollars. We're going to use surveys to report increases to health plans as well. This is something that's very important to the health plan, and this is something that they can also reimburse physicians for. Enhanced access to care means that practices are open in the sense that there's scheduling available with expanded hours. New communication options are deployed. And this is really for the convenience of patients who are seeking care. So a practice might be open on a Saturday from 9 to 12, or they might have a opening in their schedule from 10 a.m. to 12 a couple days a week so that people can have quick sick visits and they don't have to go to the ER. This is going to drastically reduce the overall cost of spending. This is also going to involve new methods of payment for the practice. So doing things like telemedicine or emailing, these are ways that practices can get paid for interacting with patients that are not just in a face-to-face environment. This is also going to eliminate a lot of overproduction and further engage the patient in their healthcare process. So looking at job descriptions and creating care teams are actual part of the transformation process into a medical home. this is really going to prevent staff from over-functioning. So we're going to take a look at what is a specific staff member's job description. We'll redefine what it is that they are responsible for. Typically when this is done, a lot of practices see that their staff are doing things that are not actually part of their job description. And so this is going to help them work more efficiently to increase job satisfaction. It's going to decrease individual workloads, and it's also going to improve outcomes. There's a big emphasis on close working relationships between all the members of the care team, which also include patients. Technology can play a big part in the medical home. And so we're looking at using a patient registry, which is really a systematic way to track patients with a particular condition. This will help ensure that they get recommended care. This should help assess and improve the level of care delivered to the specific population in the practice. For example, the diabetic, COPD, chronic heart failure patients. This should also be able to help produce performance data so that a practice can participate in a pay-for-performance program. A lot of registries will hook up to the EHR, can be part of the EHR and pull data automatically and produce easy-to-read reports. So the EHR, really is part of the whole PCMH process. It's a tool used in the patient-centered medical home. One of the big myths of PCMH is that technology and reports is all you need. Well, that's not necessarily true. A real change for transformation is what needs to take place, but using the technology and the reporting is part of that. So the EHR, depending on how it's used, depending on the practice workflow, can either increase or decrease productivity of the office. You still really have to focus on the workflow and the process of actually using the EHR in the office. In order to truly get an ROI on EHR adoption, the practice needs to undergo a redesign or transformation using the EHR in the best possible way. This all ties into the patient-centered medical home model. So when talking about certification, there are several organizations today that are certifying medical homes. NCQA is probably the most recognizable. There were two different standards. There's actually 2008, 2011, and in 2011 they got a little tougher. They go by 3 levels of certification, level 1, 2, and 3. Typically, we've got about 4,900 practices and 23,000 physicians today that are NCQA level 1. So that shows you right there that people have already begun this journey. This isn't something that's coming, down the pipeline. Your certification is good for 3 years. If you look at the actual requirements, there is a big overlap from meaningful use. So if you did a test for stage 1, you're almost halfway to or all the way to NCQA level 1 and might want to go ahead and applying. There is a lot of check-the-box requirements, which are very similar to meaningful use, so it doesn't necessarily include the practice redesign part. So just because a practice may have gotten NCQA recognition does not mean that they went through the whole transformation into a medical home. But getting that certification is going to help with payer programs because a lot of them believe that it's a really good start to medical home. It's not the end-all, be-all, but it gets you on the right path and it gets you started. So there's been a lot of medical home pilots, and these pilots have turned into reality. They've spurned programs from government, from states, from health plans, which are including pay-for-performance. And PCPCC.net is a website that tracks these pilots and also produces reports on outcomes around the country. This is showing where a lot of pilots took place over the last few years. To date, we have now 44 states as well as D.C. that have 330 PCMH laws already. Just last year, the CPCI was launched, and this is an initiative in 7 states with multiple payers. It's led by CMS. And they're taking 75 practices in each one of these 7 states that applied. They had to have already started the practice transformation process, and they're getting bonus payments, per member per month bonus payments for becoming medical homes and for participating in this program. They're going to take a long look at this and see the successes of it, and this is most likely going to be the way that Medicare goes beginning in 2014. So what kind of outcomes are we seeing from this? Well, from the pilots over the last few years, we're seeing 11% increase in practice revenue, and this is not including any kind of pay-for-performance or payer incentives. This is strictly in practice transformation and practice redesign. Physician salaries going up, reducing our overhead costs by 22%, reducing our staffing costs by 30%, and we're looking at employee job satisfaction increasing by 66%. TransferMed did a payer pilot with 25 different primary care practices, and these were some of the clinical outcomes that they saw from that. Our reduction in diabetic admission, 25%. Overall population admissions, 6%. ER utilization down 20%. 10% reduction in overall ER utilization. Generic use is going up. Decrease in diabetic patient costs per member per year, and then an average medical costs are going down by 3.6%, and that's per patient per year. A lot of health plans are now investing in the medical home model, mostly because of the numbers I just shared with you. Their goals are to lower costs, improve patient satisfaction, and engage in some type of payment reform. Just about all payers have some type of pay-for-performance program available, or they'll supply staffing for family practices, internal medicine, pediatricians, OB offices to become medical homes. So really, if you want to engage and participate in the transformation process, you can really capitalize on this financially from the health plan. I strongly recommend reaching out to all of your health plans to see what it is that they're doing, what it is they're providing primary care offices. These are just some of the examples out there today. PMPM stands for per member per month bonus payments. So if you look at, Maryland Medicare is actually going to provide $11 per patient for reaching NCQA level 3. Some of these are broad ranges, and they depend on number of conditions, and some of these are actual flat bonus payments or payments based on HEDIS scores or patient satisfaction surveys. So there's also what's called a patient-centered medical home or a shared savings program. A lot of ACOs are participating or having these today, and let's take a look at what that actually means. So if we have one provider practice with, let's say, 2,200 patients, 30% of those are Blue Cross Blue Shield, so 675 patients. Let's just say they focus on reducing their ER visits, because this is what Blue Cross Blue Shield wants them to do. So if they can reduce that by 5%, this is a savings of $9 per patient for the health plan. They also want the practice to focus on reducing admissions to the hospital by 5%, which per admission visit, the average is about $5,800 is the cost to the health plan. So if the practice can reduce that, you're looking at a savings of $372 per patient. And this is savings to the health plan. Total savings for Blue Cross Blue Shield is $257,000. That's for 1 year, just for one provider, for 30% of their population. So if they share that with the physician and just kick back 12%, which is fairly low in savings, you're looking at increasing your salary or increasing your revenue by $31,000, and that's just from one payer. So that's taking the average PCP from $167,000 to $197,000 per year. So now we're looking at including a couple different payers, and a family physician can get paid like a specialist. So what is needed to go from good to great? Really, number one is a physician or practice champion, somebody in the practice that can actually drive this message home, that can push the practice, for motivating the practice, letting them know why they're doing this and why this is important, and really be a leader in this transition. It is a difficult and long change process, so getting the commitment from the staff is really important. Transformation services. If you've never been there before as a practice, if you have not done these types of things before, how do you know how to get there? How do you know how to transform into this? There are a lot of services today that are offering help and assistance to practices to help with the transformation. Technology and information health IT can be required for really effective population management and delivery of patient-centered care. These are things like, e-prescribe, EHR, patient registries, or even risk management tools. And then communicating the change effectively to the patients is part of the process. Patients are essentially part of the care team, so you've really got to let them know what it is that's going on, how it will benefit them, and involve them in the process. So in conclusion, what does this mean for practices? What does it mean for patients? Well, we're looking at better access to reliable, high-quality care. This is going to be a better service for patients. It's a new sense their personal physician is on a team that's connected with the rest of the health system, and they're really using health IT for mutual benefit, both the patient and the practice. What does it mean for the practice? Well, it means more organized, more efficient workflow, lower cost, better revenue stream, able to participate in a positive work environment, better care for the patient, and the ability to survive in this current transition healthcare world. So if you take home questions, maybe some things to think about, maybe to look at your practice or even the doctor's office that you go to. Are they doing these things? Are they currently measuring patient outcomes? How do they know that their patients are improving? How do they know they're being successful? What data are they collecting? How are they managing the 20% of their patients with a chronic disease? Are the staff and the physicians able to go home on time? Are they able to work a 40 to 45-hour work week? Are they spending too much time on paperwork, red tape, insurance forms? How many patients can actually call their family doctor or their primary care doctor, their personal physician? Are they happy? Is your staff happy? Would you rather get paid on patient outcomes instead of volume? What is your ED and admission utilization rate, and how are you managing those to keep patients out of the ER or keep them from being admitted and then readmitted to the hospital? And then most importantly, do you have any systems in place for care coordination and care management? Well, WellPoint estimates that by 2014, 75% of all primary care physicians will be engaged in a pay-for-performance program. That's less than 1 year away, and so if you don't engage in this transformation, if you don't start to participate in patient-centered medical home activities, when will you do it? Now is really the time to capitalize on what is being offered and what is out there today, and the ability to have your practice survive the healthcare transformation. My contact information is here. If anybody would like to call me directly or email me at any time, any follow-up questions, please do. I would like to open it up for individual live questions. If anyone wants to put forth any comments or questions, we'd be happy to talk about that right now. If you're not comfortable doing so, you can absolutely send one in through email.
Thank you. If you would like to ask a question, you may do so by pressing *1 on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on your phone line will indicate when your line is open. We ask that you state your name when posing your question. Once again, *1 to signal for a question. We'll take our first question from.
Hello? Am I the first question?
Hi there.
Hi, it's Dr. Cheryl Southern, and this isn't to do with your talk today, but our Medicare carrier meeting on Monday, and it has to do with electronic medical records. A lot of does your program code?
Are you asking about EHR?
Yes.
Which specific EHR were you asking about?
Well, it's not. These are people had various different ones.
Mm-hmm.
Are
you looking
coding built into it?
For E&M coding?
Yes, because that's what people were upset about. These 3 or 4 physicians.
Gotcha. Yeah, I am not directly with any specific EHR for McKesson, but I'd be happy to connect you to the right people.
Well, basically, the problem that they're having is that they feel that the EMRs are upcoding and doing repetitive, putting things into the visits and different things that they did before and including it again. And I was thinking that this is now, that the government is now, CMS is looking at this and removing those systems or disqualifying them.
From being recognized for meaningful use?
That's right.
Gotcha. Okay. Yeah, some of the EHRs do provide the E&M coding, and some do not have that built in. It would just depend on the specific EHR.
So you could get them without that because, yes,
people
were really, they were saying that they were upcoding and
you can, or you can disable it
that they didn't want, and
right. You could disable it or even override it with the physician.
We'll take our next question from.
Yeah, hey, thanks for the talk. This is Patrick Hatch from Augusta, Georgia.
Hey,
and Eric, I understand you're not affiliated with any of the EHR products, and I had kind of a direct question about registries in the Practice Partner product. So I'll just email you offline. The question has to do with maybe the roadmap for registries in Practice Partner. Right now, you kind of have to work with patients individually, even though you could see the entire registry at a time. There really aren't any export functions or batch functions for working with registries. Do you know, are you privy to any information about where McKesson's going with registries in that product?
Yeah, that's actually a great question, and we will have a solution for that very soon. Yeah, I'd be happy to share that with you as well. So they're looking at a couple different options to actually pull the data from Practice Partner automatically, and the ability to drill down, by patient or even look at overall population that will help you manage the patients as well as participate in a pay-for-performance program.
Okay, great. Thanks.
Yeah, absolutely.
I'll contact you offline later for that.
Perfect.
As a reminder, *1 if you'd like to ask a question. We'll take our next question from.
Yeah, this is Scott. I'm in Albuquerque, New Mexico, and we do billing for many physicians. And I want to clarify that the billing process as far as coding and submission of claims data to insurance companies for reimbursement, will that remain the same?
I believe so, yes. What you're going to look at, though, is a lot of insurance companies are actually providing higher reimbursements to doctors that have become recognized for NCQA or have done certain measurements that are important to the health plan. So I've seen, I think Florida Blue Cross Blue Shield, if you become NCQA level 2, they up your reimbursements by about 18%.
Okay, but the submission of the data to the insurance company would remain the same, coding, diagnosis.
That's correct, yes, sir.
Okay. All right, that was my question. Thank you.
And there are additional codes that can be used in a medical home as well, and additional codes that you can use as far as care management and care coordination.
Okay, so it's our responsibility to find out what those are and make sure our clients are aware.
Yeah, I definitely would, and I definitely would even reach out to the health plans for some of that information, or have your clients reach out to the health plans.
Excellent. Thank you.
Sure thing.
As a reminder, *1 for questions. We'll take our next question from.
Good afternoon. My name is Heather. I'm in Lawrenceville, Georgia.
Hi, Heather.
I was wondering if you would please explain the scoring system for becoming a patient-centered medical home. Like, how does the scoring work?
Sure, absolutely. They do it based on points, and you can actually go to the NCQA's website and print off some of their measurements. And what they'll do is, based on how many points you hit, you can become level 1 or level 2 or 3. Once you hit that number, you become certified, and you can always reapply if you believe that you've now done some changes and implemented those.
So we've printed off the standards, and it has things on there like you can meet it at 75%. Does that mean that you're going to get 75% of the points?
That's correct.
Okay.
Yeah.
Okay. Thank you so much.
So if it says like you have to meet 75% or 80% of a specific measure, you would get full credit for those points if you hit that for your overall patient panel, or we're doing that for 80% of your patients.
Okay, I don't understand. I'm sorry.
So, like for a specific NCQA measurement, if it said if you have to do something for 80% of your patient population or 80% of your chronic disease patients, you wouldn't have to do it for 100% of your patients, just 80% in order to hit that measurement and get those points.
Okay.
Does that make sense?
That does.
Okay.
We'll take our next question from.
Hi, my name is Pam Stickler, and I'm from Clarkston, Washington. And I want to know where specialists fit into this medical home model.
Great question, and there's actually been a lot of talk about, almost a medical home for specialists, but really the supporting the primary care physicians or working with the primary care physicians is going to benefit both their patients. So it's going to help both ends of the spectrum, doing the specialists as well as the PCPs.
Okay.
Once again, *1 if you'd like to ask a question. We'll take our next question from.
Hi, this is Laura from Mackinac Straits in Michigan.
Hi, Laura.
And we are working with the Blue Cross Blue Shield program in Michigan. We've nominated and hopefully accredited in the spring. How important is it for us to consider doing the NCQA also?
It really depends on your payers or your health plan. The NCQA does cost money to apply or to become accredited, and there is a lot of work involved in getting that ready. So as far as the actual application, I would see if there's any kind of additional reimbursement or additional financial incentives for you for doing so. Because the transformation process is really where you and your patients are going to see the most value. But if you go through the whole check-the-box NCQA application, it would be nice for you guys to get rewarded for it. So I would definitely encourage you to reach out to all of your payers to find out what they're doing if you do become recognized.
Okay, thank you.
A final reminder, *1 for questions. There are no additional questions in the queue at this time.
Perfect. Well, again, everybody, thank you for joining, and my contact information is here. Feel free to email me any questions or any follow-up comments. I'd be happy to respond and love to hear from everybody.
That concludes today's conference. We appreciate your participation.